Hello, everybody. I am very sorry that I cannot give this talk with you in the room, but anyway, I will try. I will try my best. It is my pleasure today to talk to you about 3D visualization of valves for interventionalists before, during, and after interventions. This, of course, is one of the initial images that we obtained on the mitral valve. And this is just to tell you that the 3D imaging of the mitral valve started in the year 2007 in this study, which is one of the first we did, we were lucky enough to do it at the University of Chicago. We rapidly found out that whatever we find in a 3D echo mimics entirely what the surgeon finds at the time of an operation. And this, in the top here, is an atrial septal defect, and here is a flail P2 with a ruptured cord. All of this, of course, led to this idea that we could use 3D echo for guidance of procedures. And this is an example of the year 2008, in which we were taking, for the first, I think, times, a 3D echo machine in order to do guidance of ASD closures by using a 3D echo. And this, of course, is Dr. Hijazi. It became obvious also that the views that we obtained with a 3D echo mimic entirely the surgeon's view of the mitral valve. And we can find the proximity between the aortic valve and the mitral valve. And we can see, of course, the anterior leaflet, which is not separated by these indentations here, separating the posterior wall in P1, P2, and P3. All of this information led to the formation of these heart groups that we all are seeing in universities now, in which we see this interaction between interventional cardiology, cardiac surgery, vascular surgery, cardiac anesthesia, and of course, we in cardiac imaging who have a big thing to say. And this, of course, led to the use of three-dimensional echocardiography for the use of most of the procedures. Indeed, many of these procedures cannot be done if we didn't have 3D echo. And of course, a mitral clip is one of those examples. When you want to fix a perivalvular leak, as you can see here, a PVL closure is another one of those examples in which 3D echo is paramount in order to perform this. Three-dimensional echo added to the information provided by angiography has a lot of advantages. It provides real-time 3D anatomic definition. It allows the visualization of structures in multiple planes. And of course, it minimizes radiation and exposure, and of course, I think increases safety. Part of the limitations of using 3D echo here is that many interventionists are not used to these echo perspectives. 3D echo at times gives you a worse definition of intracardiac catheters, and 3D echo is, of course, very much dependent on image quality and operators' experience. This is an example of now the combination by performing fusion imaging of a 3D echo, which has been fused together with the radioscopic imaging. And this is a patient here who has a perivalvular leak. And this, of course, is very useful to guide the interventionist as to where to perform this type of procedure. And this is just to show you the overimposition of a 3D catheter with a catheter observed by angioscopy. Another area in which 3D echo is becoming extremely useful is in the quantitation of regurgitant lesions. Regurgitant lesions are much more difficult to quantify than the stenosis. And now for the first time, we see the overimposition of real good quality of 3D echo together with the structures, as you can see in this patient with mitral regurgitation, in which we can see this area of flow convergence. The development of different types of methods are becoming extremely useful. And the development of novel semi-automated methods for quantification of mitral regurgitation is something that occupies quite a lot of time. This is an example of a patient with degenerative mitral regurgitation. When you look at the CW across the mitral valve, you can see that there is a late murmur of mitral regurgitation. And you can see that with this new program, we can look at the instantaneous regurgitation, and we can actually look at the timings and obtain instantaneous information about the volume flow. Differently to what happens in patients with functional mitral regurgitation, also represented here by the CW, we can see that in functional MR, the flow crosses the mitral valve in two humps, one in early diastole and one in early systole. That is very nice represented by this particular program. Another manner in which we can look at the valves at the time of structural heart programs is using virtual reality. And virtual reality is a computer-generated simulation of three-dimensional images. And let me show you some examples. This, of course, this computer generation of a three-dimensional image is a human that is interacting with these goggles, which interact with special electronic equipment, a helmet that has a screen inside with gloves and sensors. And there is an area in the room delimited by the sensors in which images can be visualized. Now, this, of course, virtual reality has a lot of advantages. On the left here is the way that probably Dr. Narula and myself and many others learned anatomy with the use of cadavers. This is how younger or current medical students can study. And you can see that by using virtual reality, you can look at all of these type of models. You can look at the different types of structures to which you can add or discard the different levels to which you would like to study. This, of course, is an example. We applied and developed this possibility of looking at virtual reality from three-dimensional echo structures. This is a patient with a prosthetic mitral valve. You can see we are taking it out of the screen and we are making it be in space. This, of course, is really big, and we can actually go inside this type of data set. And of course, we are now starting to do courses in which we can show and teach anatomy using virtual reality to 20, 30 physicians all at the same time, which are all visualizing the same type of data set. This, of course, facilitates education and training, the communication with the surgeons, and allow us to also communicate with the patients. This is sort of what we're using virtual reality now. This is how we simulate different types of procedures. This is, of course, the base of the left atrial appendage. We can do all the types of measurements that are required to use an occluder. We can then go to the shoe shop and find a particular occluder, place it, and deal with this data set to see how this fits and how it would look. So this, of course, is now, this is very preliminary work in which we are trying to do this simulation of procedures on the mitral valve. And to understand when we do these replacements, what would be the best shape. We can then, once we have the shape, obtain, in this case, a bioprosthetic valve, and we can place it and see how that particular type of valve will interact with the surrounding tissues. Let me just show you some examples of before and after in different cases of structural heart disease. So one of the facts is we're going to start here. You can all recognize this case of mitral stenosis, in which we see in the appendage, we see actually that there is a thrombus. With 3D, we can very nicely see both the mitral valve from the left atrium and the left ventricular perspective, in which both commissures are completely fused. And of course, with the insertion of the Inouye balloon, we can then exactly see and measure with three-dimensional echo. Once this is dilated, we can see the actually fracture of both commissures. And using 3D echo, we can do the most accurate measurement, because with 3D echo, you can actually orient yourself perpendicular to the tip of the valves with no assumptions regarding the quality. Let me show you, all of you would have made here the diagnosis. We see that this patient here has a bioprosthetic mitral valve, and there is a very large perivalvular leak, as can be seen in the color. This is again an example in which the his mitral valve is extremely large. With 3D echo, we can see that this will be very difficult to close with 1, 2, or 3 amp platters. And so this is, of course, extremely useful, because with 3D echo, with 2D echo, you many times do not get that type of information. With 3D echo, we can definitely identify the paravalvular leak with the use of color. We can guide the placement of the wire, and then we can do the successful closure with an amplatzer device. Let me show you an example of how the use of 3D echo is particularly efficient here. You can see with 2D echo the presence of 1 or 2 perivalvular leaks. You can see this area clearly of the hissens of the ring. And with the use of color, we can see that the color is occurring on these 2 particular types of defects. We guide the placement of the wire, and we place an initial amplatzer device. Let's see that there is a remaining perivalvular leak. So we can actually guide the placement of a second amplatzer device with the use of 3D echo and get a very good result. This, I think, is also a very good example how you can go wrong if you only do an assessment with 2D echo. Another patient with a single perivalvular leak, and you can see that when you do 3D echo, you clearly identify 2 perivalvular leaks. This is again another example that I'd like to show, a patient with a mechanical bileaflet valve, in which we're trying to pass a catheter on the outside of the ring in order to use the amplatzer device. Here we can see that the position of this wire is incorrect. This is very difficult to make this type of diagnosis using just by using fluoroscopy. Well, the use of mitral clips is sort of now used frequently. I think 3D echo allows you very beautifully to understand exactly the position of the flail P2. You see that there is also an additional P3 prolapse and the rupture of 2 cords. Using different types of coloring schemes, it allows you to see that, and we can see actually the ruptured cords very nicely. With the use of color, in this particular example, we can see exactly the localization of all of this regurgitation. This is an example of a patient with a P1 prolapse, and you can see how the color is escaping from behind this P1 prolapse and expanding as a fan to the entire left atrium. This is an example of a patient again with, even with regular 3D echo, it's difficult to see. Once we use this rendering techniques, we can see that there is a perforation on this prolapsing scallop. And from this perforation is where most of this jet of mitral regurgitation is happening. Let me show you this. I think is a beautiful example of a patient with functional mitral regurgitation, in which we visualize the left atrium as it would be, the mitral valve as it would be in the left atrium, or as if we are in the left ventricle. We can see this jet of mitral regurgitation, and you can see it as you see it from the left ventricle. These are all images that could not have been done. And after the placement of 2 clips, we can see that we have improved the mitral regurgitation a lot, but there is still a remaining jet. And we can visualize this jet from the left atrium or from the left ventricle and understand exactly where is the location of this. This is just to show you how we have improved. This is a patient with an Alfieri done by a mitral clip. This is the 3D that we used to get. This is the 3D in which we insert a source of light in order to create shadows. And here you can see how nicely we can see the openings and these borders, how clearly these borders are seen. And we actually make the adjacent tissue more transparent. We can start seeing very nicely the clip that we had not seen before. Let me show you now an example of a functional mitral regurgitation in which we see this papillary muscle, the cords are taut, the restricted motion of the posterior mitral valve leaflet. In 3D, we see this sardonic laugh with a lack of apposition in this portion of the valve, mimicked by this sort of laugh in which we see this opening. And you can see here that the mitral ring has lost its size or its morphology. And you can see that there is a lot of tenting, and you can see that the coaptation here of these leaflets is much, much narrow. And this is how you see this again in 3D. I find this extremely useful because it is very useful for me to guide people, guide the interventionists as to what is the perfect position in order to do this closure of this mitral valve. And you can see very nicely, again, the imposition of this glass-made tissue with a color Doppler. And again, the same type of situation now in a patient with, again, functional MR, but this is non-ischemic, in which we have the central jet that collides with the roof of the left atrium. Here we don't see the sardonic laugh, but we see that there is a lack of coaptation of the leaflets all throughout the coaptation area of the ventricle. Just another very nice example. Many times we encounter these patients. These are patients that have mitral regurgitation in a transesophageal study. And when we look at the structure, it's very difficult to put them into a Carpentier classification. Sort of difficult to understand what is causing this moderately severe mitral regurgitation. And when we do actually a 3D echo, we can see that there is a cleft occurring on the anterior mitral valve from where this jet of mitral regurgitation. So things that we were not even suspecting upon, we can see. And again, for all of these more complex procedures of valve in valve, you can see very nicely. This is, again, the mitral valve with two of the leaflets that are immobile. This is, again, looking at this mitral valve from the left ventricle looking up. And after the placement of a valve in valve, we can see how nicely we actually see this. This, again, is a valve in valve now in the tricuspid position. You can see the lack of opening and the success after the placement of the valve in valve. 3D echo of the tricuspid valve is something that we are all now learning how to do. The big advantage of 3D echo of the tricuspid valve is that we can see the three leaflets. These are images obtained from a transthoracic point of view. And this is just to show you that with 3D echo, we can truly understand where the malcoaptation is occurring. There is an ICD, where the ICD is interacting with the tricuspid valve, resulting in malcoaptation. And this is an example from Houston that they were kind enough to lend me. This is a patient, again, in which they did pre-procedural planning by modeling the tricuspid valve, by printing the mitral valve, and then they used the same clip in order to create an Alfieri of the tricuspid valve, in which you can see that very nicely. All of this obtained also, of course, with 3D echo. And this is, again, another example of a patient here with a tricuspid valve that has a lot of stenosis and mitral regurgitation. And again, here the placement of a valve in valve, in which we can very nicely see at the time of balloon inflation. The device is now being deployed, and you can see very nicely success. All of this guidance done with the use of 3D echo. So I think, now to finish is that interventional echocardiography displays the anatomy for you. It allows you to do a pre-procedural assessment. We use it in every case to do guidance inside the procedure, and it's extremely useful for our post-procedural follow-up. So I think that echo and structural heart disease are married, and this is a marriage that will never allow a divorce. And I hope that you all are learning this great technique. And thank you very much for your attention. Thank you again.